afternoon, everyone. My name is Julie. I'm part of New England QIN-QIO. We're going to get started now. Just want to let everyone know, please mute your line if you wouldn't mind, so we're not hearing individual conversations during the webinar. Okay. So I'm going to be your moderator for today's webinar. This is Interact Session 9, the final celebration. So if you aren't familiar with this, Interact has proven to lower readmission rates when the program is followed and the tools are utilized. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives in order to improve patient safety, engage patients and families, and, of course, improve clinical care at the community level. So thank you for joining us on our 9th series for 2017. So before we get started, we just have a few housekeeping items to go through. So the first thing is that this call is going to be recorded for training purposes, and I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We're going to take questions at the end of the presentation. I'll instruct you on how you can ask a question over the phone, or if you want to pose a question in the chat box, that's absolutely fine. So please be sure to send the question when you pose in the chat box to all of the attendees. So this time I'd like to introduce Carol Dietz.
Well, good afternoon, everyone. I hope everyone had a great Thanksgiving holiday and a nice long weekend if you didn't have to work. And thank you so much for joining us on our last session of the year on Interact. It's our final celebration. And Florence and I are so pleased to have you join us today. So, with that being said, today's session, we're going to be going through understanding that this is a journey and that it's ongoing, and in order to get it part of your culture, you need to address it every day, talk about it every day, and see where the gaps are, and then working with your team. This is not a one-woman, one-man show. It has to be a team effort to address those gaps in the use of the Interact tools, and then making sure that you have those shored up to move forward. Florence is going to describe what an Interact nursing home should look like. And again, yes, we're in our 9th month, but neither Florence, myself, or Sheila expect any one of your nursing homes to be perfect, to have every tool in place. As I just said, this is a journey, and it takes over a year to truly implement the tools, and then to make sure that the tools are working for your institution. We're going to talk about some lessons learned from nursing home colleagues, and again, we want you to celebrate. Even if you have only implemented 5 tools, that is 5 tools that you're helping your patients out, you're helping your staff communicate better, and providing better care. So you have to celebrate. And hopefully, maybe your institution will get you some pizza or some ice cream or something. That'd be really fun. So before I turn it over to Florence, who's going to talk about what a nursing home, Interact nursing home should look like, I want to review all the requirements that a nursing home has to achieve in order to get a participation certification. And many of the hospitals now are looking for this certification of participation. So please know it's a hot commodity, and we are very careful on who gets it. We want to make sure that they have achieved all the requirements. So the first one is the minimum participation in the Interact webinars. You have to have participated in 7 out of the 9 webinars. And I apologize, that deadline is incorrect. It should say January 16th, 2018 is the deadline to get all these done. What you can do is, if you haven't, I think I'm going to go through that in a minute, if you've listened to 5, if you've participated in 5, you can listen to 2 online. You can only listen to 2 online. So that's when that deadline to complete is, again, January 16th, 2018, and we will have this corrected before we put it on our website. for you guys to review. So that's the first one, minimum participation in the Interact webinars. The second one is you have to send us, meaning Paul and I here in Connecticut, at least 4 months of readmission data. And again, the deadline to send to Paul and I is, that's another incorrect date. It's January 16th, 2018. So you have to the middle of January of next year to send us your 4 months of submission data. And you can either use the NNHQ website to submit your data, as long as you submitted also a data use agreement, a DUA, allowing Qualinon to access your data so we can review it. Or you can send your facility's readmission data by email or fax, but you have to have at least 4 months. Or you could use your corporate tool if your corporate is using a different readmission tool. This is the tool that we use. We're going to update it for 2017. If you need to have a copy of this, we can send this to you, and then Julie will help walk you through how to submit your data if you don't have a readmission tool right now that you're using. But again, we highly recommend using the NNHQI tool on their website, the readmission tracking tool. So we have those two that you have to do. Then the third thing that has to get done is that your nursing home administrator needs to complete the Interact implementation checklist, which Julie will be sending out with the thank you for participating, and also we're going to send it to each and every nursing home administrator that has signed up to receive the participation certificate. So be on the lookout for this certificate. This is not a certificate, I'm sorry. This checklist, it has to be completed, and this deadline is correct. I did one thing right. And again, it has to be sent to us. It has to be in our hands by January 16th, 2018. This is what the implementation checklist looks like. It's a one-page document. And you're basically telling us where you are, where your facility is in implementing Interact. One of the things that Florence and I and Sheila have stressed over with the last years is that everybody checks, yes, we're there, yes, we're doing everything. We don't want to see that. We want to see the true placement of where you are in your implementation of Interact. Your journey. We don't, again, you're telling us where you are, so therefore we can reach out to you to say, where do you need help, or we can help you with this. This is a true picture, and this is what you should do on an annual, if not biannual basis of looking at this implementation checklist with your team to say, where are we, where have we got some real hold on these tools, and where are gaps. So this is the implementation checklist that has to be completed. It has to be signed by your administrator and then sent back to us. And again, Julie will be sending this out to everyone that has signed up. We are doing it. Okay. If you could please put your #6. Yes. Please put yourself on mute. Great. Thank you.
I don't know if you're on mute.
Okay.
The leader has muted your line. To unmute your line, press #6.
If you participated in 5 out of the 9 webinars, so you can listen to 2 others online. On this slide is how you can access the New England QIN-QIO website. It's www.healthcarefornewengland.org. And once you get on the landing page, you're going to click on the Events tab, scroll down to the previous events, going to click on the month to find the session that you have missed, And then you're going to click on the webinar recording link, and you need to fill out the information before downloading the webinar presentation. That's how we track everyone. And yes, we want your name, but we also need your nursing home facility's name. And please don't just put Apple. You know, if you're Apple Saybrook or Apple Colchester, that's what we need, not just Apple, please. We need as much information as we can so we can give your facility credit. These are the dates that all our webinars occurred in 2017. And again, this is just a nice reference for you to say, oh, you know, I missed the one in August or I missed the one in June. And that'll make my 7th or 8th or 9th one. I mean, the more you listen to them, the much better it is. So you'll understand all the different tools that are out there. So again, congratulations for those nursing homes that have done it, that have done all the requirements, you know, sent us your data, and then you're going to be sending us your Interact checklist, your implementation checklist. So, and please celebrate with not just your team, but the entire facility, because this is what it's all about. It's a quality improvement program, and it should be embedded in throughout your facility. With that, I'm going to turn it over to Florence, who's going to talk about what an Interact nursing home should look like.
Good afternoon, everyone. I hope that you can hear me clearly.
Yes, we can.
I am excited. I'm just as excited as Carol to be celebrating this journey with you as we wrap up the training session part of Interact implementation. Like Carol said, this should be something that is continued on, even though we're not here anymore to support you closely. But know that we are here from a distance if you need anything from us, and let us know if we can help you in any way. So the Interact home, again, is not about check boxes. It's not about checking to say, I've done this, I've done this. We really want you to change the culture in your building. This Interact is really about communication. It's not about another project. It's not a QA project. It's not a QAPI project. It's about looking at how you communicate with yourself in your building, and then looking at how you communicate with your stakeholders, your nursing home, your hospitals, your emergency service providers. Because when you drill down to all the issues that occur with transfers in and out of the facility, it all comes down to how we communicate with one another, and to make sure that we have the same shared mental model about what is actually going to happen as we transfer our resident. And when you look at the whole picture, it's all about that resident and keeping that person safe if we have to transfer them. Okay, so the Interact website has changed. The name now, you see the web address on the slide right now. When you go on, you're going to be required to actually fill out a document that talks about your name, your facility, all your demographics. And then you have to develop a username and password to be able to gain access. There's no cost for it. The tools are still available for you to look at, to download. But if you need to order the tools, you can go through pathways to order the tools. And I have to do the same thing when I go on, so it's not anything that's different for you than for me. Next slide, please. So in the beginning, we talked about developing an Interact team, which you can link to any other team that you have already existing. It's looking to make sure that it's a multidisciplinary team. You want to make sure that you have representatives from all areas of your facility, because everyone in the facility is involved in communication and picking up subtle changes in your residents. So don't discount the people in front office. Don't discount those in dietary, because they get to see your residents as well as the clinical staff. It's essential to have frontline staff involved in any of this work. When you're having your meetings, it's important to set a date. Actually build out a calendar for the year instead of waiting till a week before to say, okay, this day sounds good. If you have a standing monthly meeting, then everyone knows that on the second Tuesday of every month we have a meeting, and this includes talking about Interact and what we're doing with Interact. It's important to set up meeting norms, and these are just general information on any groups that you're meeting, any meetings that you're having in your facility. Set up norms, which include being on time. If you're late, we're not going back to start over. You just have to pick up where we're at when you come in, and the rest of it you have to catch up in meetings. Do not go back and try to catch everybody up because you'll never move forward in your meetings. Cell phones should be put on mute. And if there's an emergency, take the call outside of the meeting, not try to have conversations in the meeting. Make sure that there's only one conversation at a time going on. So those are some of the norms, but you can figure out what works for your own team. It's important that you always review data when you're having a meeting, especially when you're talking about Interact and readmissions. You have to come with data to show either whether you're improving or you're not improving. If you're not improving, let's look at what are we doing that we can change to affect the change that we want to have happen. Important to always have different departments report out on what they're doing so that everybody in the building knows what each other is doing. And it's also important at the end of every meeting to summarize what's been discussed, give out any to-dos if people have items that they're responsible for, to make sure that everyone leaves the meeting understanding what's been said, what's going to occur, and what your assignment is as you're leaving the meeting. Next slide, please. So Carol talked about submitting data. My preference, and I know my two colleagues kind of beat me up a little bit about it. In the beginning, I wanted you guys to submit a year's worth of data. They beat me down to 4, and my preference would be that you submit your readmission data to the National Nursing Home Quality Improvement Campaign. And you see the web address on your screen, nhqualitycampaign.org. You would need to click on to the Safely Reducing Hospitalization Tracking section, and then just follow the tab to get you to where you need to be. If you need any help with this, please give me a call, send me an email, as in Florence, Johnson@qualidine.org, and I will walk you through it. The reason that I recommend this particular portal is that when you submit your data, you're getting benchmarking. You're getting benchmarked against yourself, nursing homes in our state, and nursing homes nationwide. And it's more quicker information than you would get from CMS, which is 6 months behind. You would get this as only a 30-day lag. And if you go onto their site, there's other information that you can get about quality measures and all this information to help you in all the different areas that you're focusing in on. I know we're talking about hospitalizations right now, but if you go onto that web portal, you will get information on pressure ulcers, falls, mobility, infection. So if you're doing quality improvement, you really need to basically live on this website. There are resources there, and you can also customize their resources and put your name and facility contact information on that. Again, I'm available to talk you through it if you need any assistance with that. Next slide, please. So once you have downloaded your tracking tool, we talked about this, saving it onto a shared drive. It's important that you complete all the required fields. And I hope that if you're on this call on this particular day, you are way further ahead on any of this information on the screen. You want to put in all your starred items, which are the required fields, minimally putting those in will give you your 30-day readmission rate. However, the more information you put in for each tab, the richer the information that you get back. So those of you who are using this already understand that you get information drilled down to date and time and the person responsible for sending out your residents. It also tells you where your residents transfer to the most, the diagnosis that sends them out the most, where you're getting your admissions from, what nurse, what shift. So the more information you put in it, the better you'll get the information that you receive back. Next slide, please. So, you guys know I love questions. So here's my first polling question to you. Does your frontline staff and families know what your readmission rates are? Please answer and then click on submit to make sure that we receive your response. And I like this question only because I've had presentations with non-clinical staff, and I've asked the question, do you know what your rates are? And they don't know it, which is very surprising to me. The last presentation I did had a mix of frontline staff as well as leadership. And some of the DNSs couldn't even tell me what their readmission rates are. So that's kind of concerning. That's information that should be shared. Okay, the poll has ended, and we'll wait for the response to see what the answer is. Okay, while we're waiting for that, let's go on.
There you go.
Okay, there it is. So most people said no, and more than half of you did not answer. So those who didn't answer, I'm putting you in the no category. So if you're in that no category, please go back, find out what your rates are, and then go on to share with your staff. If you're working on a project, any quality improvement project, all your staff should know what your rates are, what your data is, so they know what they're aspiring to achieve. So if you're telling me we need to improve falls, and I don't know what our rates are, what am I working towards? So I need to know, firstly, what are my goals, where do we want to reach, and then secondly, where are we today? Then I have something to reach for. All right, next slide, please. So it's important that you look at your readmission rates. As I said, it should be shared with your staff. Leadership should definitely know what it is. I don't know, some facilities have a keeper of data. Whoever that person is should be sharing this. It should be shared during, not just during medical staff meetings. If you're doing QAPI projects, all your data should be shared on all the different goals that you're working on so that people know exactly where you are. I believe that you should post things where your family should know. When you look at trying to be members of a ACO or preferred provider network, that's what they judge you on, your length of stay and what your readmission rates are. So why not share with everybody and be proud of where you are? And if you feel as if you have work to do, share that also and show your staff why you keep pushing on them to be better. And definitely your medical staff team members should know where your rates are. And the quality improvement tool, which is the root cause analysis document that Interact developed, that's to go back and look at a transfer that has occurred. It could be tedious, but it's looking at what happened, why did this person need to be transferred, who are all the players that were involved in the transfer, including your medical staff, your nurses, your CNA, who saw that the need for that transfer first. Is it possible that it was something that occurred a few days ago that we could have attended to? So this really wants you to get down to what happened and what could we have done differently to stop this from happening. Also, please remember this is not a finger-pointing exercise. It's not to nail anybody to the wall. It's looking at our system, our process. How can we improve that? And if we're too involved in finger pointing, we will never get to the point where we're actually addressing process problems and issues. And then you have your med reconciliation. I should have actually made this into a polling question to find out how are people doing med reconciliation. Are you really doing med reconciliation? There are some tools on Interact. If your corporate body has a tool that works best for you, then that's fine. But it's really important that med reconciliation is being completed. That means looking at your diagnosis and making sure that every medication that's ordered has a diagnosis to go with it. If a resident went out on a med and came back without it, contacting the physician. Was this an oversight? Was it really meant to be DC'd? And then just have a discussion. Med reconciliation should take more than 15 minutes. It's done properly. Next slide, please. Next slide, please. Thank you. So we talked about different types of communication tools. We looked at Stop and Watch, which was developed just to catch subtle nuances. Hopefully, if you're practicing Interact in your building, you have consistent assignments, because that's how Interact works the best. It's about knowing your resident. So if I'm taking care of Mrs. Jones every day, I know her nuances. I know when she's not looking well before she even says anything to me. But if I'm bouncing back and forth, I don't develop a relationship with anyone really. I don't get to understand what their subtle changes are. So Stop and Watch is really for all non-clinical staff in your building, from the receptionist all the way up to even rehab. Your people in the business office, anyone that has contact with your resident, as well as their families. Remember, families take their family member out sometimes over the weekend. They take them out for hours at a time. If anything occurs while they're out, it's important that they be able to communicate that with us. So the Stop and Watch tool should be available, and it should be pocket-sized so it's not overwhelming, to be given to family members as they go out with their loved ones, and explain to them why they're taking this tool with them. And then when they come back, if they don't automatically give it back to your staff, staff should be asking about the Stop and Watch tool. SBAR, clinical, we all understand that it's about documenting why this change is occurring. Please don't only use the SBAR when you're transferring. Anytime there's a change in condition, it should be completed automatically before you call either the physician, your APRN, or your PA. Once it's completed and you make your call and if a decision is made at that time to transfer, you already have your story written, versus I'm going to call the physician first and then I'll complete the SBAR. SBAR has all the data that you need to report off to the physician. My goal is to get to the medical directors and the nurse practitioners group to have them help us with this and insist that people have the SBAR completed before they report off to them on what's going on. The nursing home transfer form is what we are now using instead of the W-10. Our DPH gave us permission to replace the W-10 as we know it with the nursing home transfer form, which has far more information than the W-10. And if you need any background or any supporting information about that, we can get you a copy of the letter from our DPH. When you use the nursing home transfer document, you will also need to attach your face sheet because that has the insurance information. You should also attach your capabilities list when you are sending your resident out to the facility. This lets the hospital know what services you're capable of offering to your residents when they are being sent back to your facility. The capabilities list should be reviewed minimally every quarter. That way, if there are any services that you no longer offer, you remove that. And if you have new services that you're offering, you add that to your list. So it's not a one and done. It should be a fluid document that is looked at every quarter. And then on the top of on top of everything that you give out in the red envelope, you have your acute transfer checklist, and it just checks off everything that is included in the envelope. Please do not make your EMS group sign this document. They don't have to sign it. Don't let that be a barrier with you getting your resident out as quickly as possible. Okay, next slide, please. The red envelope. So everything I just really talked about, except for the stop and watch, go in the red envelope. So this is how you communicate with the outside world. It should contain your transfer checklist, your SBAR. The transfer checklist is on the outside, but inside is the home to hospital transfer form, your SBAR, your capabilities list. It should also have a copy of your most recent NAR, because right now we can't think of any other way to get the list of meds to the hospital. It should have a face sheet, advance directives, if someone is concerned, any document that would be necessary to provide to your resident. Because what's in the red envelope tells the story of why the resident is coming to the hospital, and then also gives them all the documents that they need to provide care. So if they need to call a conservative to get permission to do something, they have that in their red envelope. The red envelope should not be opened by EMS because you're going to give them a copy of everything that's in that red envelope. The red envelope should really go to the triage nurse upon entry into the hospital. So UConn Healthcare Center is expecting to see the red envelopes in the ED. So if you're a member of the DREAM team and you send residents to UConn, they will be looking for the red envelope. ECHN is also expecting the red envelope. We have found that it's kind of slipped in by the red envelope. So we plan on rejuvenating this with EMS and the emergency departments because this is best practice for transferring your residents. And the biggest thing that comes out of this red envelope process is that the hospital has a phone number of a person to contact at the nursing home if they have any questions. And please remember that along with the red envelope, you should also practice warm handoff. So you should be calling your ER to say, I'm sending Mrs. Jones. The red envelope is coming with her, but here's why I'm sending her. Just a quick, brief overview of why you're sending Mrs. Jones to the ER. Next slide, please. So here's my polling question. Is your facility currently using the red envelope system for acute care transfers? Give us a minute to get the question pulled up. There it is. Please do not forget to hit submit so that your response will count. As I said, the team here at the QIO is planning to get back out in the field and assist the stakeholders who have had multiple staff changes in getting this rejuvenated. I know that some facilities have come to me to say, we're doing what we're supposed to be doing, but either it's not getting to the hospital or some EMS staff is saying, what is that? I don't know what it is. All right, it looks like we have about 50% of the people using the red envelope. That's great. 8 who did not answer. Again, I'm putting you in with the no people. So hopefully at the end of this, we will have 100% participation with the red envelope. Really want Connecticut to get on the map with having one standardized system for communicating between our nursing homes and our hospital. I think we really owe it to that resident that we take care of. All right, next slide. Thank you. Then we also talked about your decision support tools, the changing conditions, file cards, the care path, and these are evidence-based tools to help guide staff in providing care, especially useful with either new grads or someone who has been out of the field for a while and is coming back into the workforce. It really guides critical thinking and how to provide care. Next slide, please. There's also a section with advanced care planning. It's a scripted guide on how to facilitate discussion with your residents and your families. Advanced care planning should be part of every RCC. This way it ensures that any conversation about what the resident's wishes are is documented. It also allows you to discuss this in a non-threatening way. It also allows you to discuss it when it's not an emergency. So when the resident is about to be transferred or when the resident is in the ER, really is not the time to start talking about what your wishes are. And as our residents mature over time, it's important to look at, okay, is it still relevant that you want to be a full code even though you're in stage whatever your illness is? If you're 93, do we really still want you to be taking 50 billion meds that don't, at this point, don't address whatever your areas of concerns were when you came into the facility when you were 60. So it's really about knowing your resident and making sure that this is person-centered care. Making sure that your care plans reflect who your resident is today, not who they were a year and years ago. I've looked at care plans and I've seen care plans that say, we'll adjust to new environment, moving into nursing home, or skilled nursing facility, and the resident's been there for 10 years. Is that still relevant? So it's looking at the relevancies of what's going on with your resident. In the advanced care planning section, there's resources on how to talk to your families about hospitalization. Not just do you want them to go out, but what happens to them when they go to the hospital. Not do you want CPR, but what happens to your body physically when CPR is performed on you. Not should you have a tube feeding or not. What happens? What are the end results of you having a tube placed in you for feeding? Not always the answer. So please, if you have not had time to look at this section of Interact, it's important that you do that. I refer people to this all the time, and it's very relevant information that's written at the level that a layperson can understand it. Also guides, there are guides in there to help your staff as far as to when to decide about palliative care. When is that appropriate? When is palliative appropriate versus hospice? I think sometimes we talk about those two things as if they're the same, but they're not. Palliative care is so much more different than hospice care. So please take a minute to look at that. If you're not the educator on this call today, make sure that your educator goes and looks at this section. And your social workers, they do the RCCs and they do a lot of the communication with your families. Next slide, please. So again, you're doing great work with Interact. You're doing what you're supposed to be doing. You're actively implementing. It's important that you report off to your staff at any opportunity that you get. Your medical staff meetings, when you have your regular meetings, either with your nurses or your team, it's important to talk about we're doing Interact. Here are the tools that we have been able to implement so far. Have a storyboard. Have a QAPI board, not only on the lobby level, but on each unit to keep your staff engaged. It's difficult to get everybody at the table at the same time, but if you have a board that they can go to see what's going on in the building, especially during off shift, after hours, on the weekend, to keep people engaged and to make them feel as if they are a part of what's going on in their building. Next slide. So here's the implementation checklist that Carol talked about. We will need you to complete this. It's about being brutally honest with yourself. What have we been able to implement so far? And when you send it to us, if you started a tool, but it has not really grown roots and has become something that you're doing all the time, make sure you acknowledge that at the bottom. Leave us a note that says, I started this, but it fell apart. And then maybe we can reach out to you and figure out how we can help you to relaunch it and to make it stick better. I'm always willing to come out to a building if you need to be in person and providing education and my cheerleading skills to your staff. So yes, make sure you're looking at your implementation checklist, not only just for us, but for you to know where you are and where you're headed. Decide which tools are more important that you implement right away, and then the other ones you can implement as you go along. Next slide, please. Okay, so that's it for me. I think we're going to open up the lines now to have questions. And, all right, Jules.
The leader has unmuted your line.
And thank you, everyone. At this time, we're going to take some questions. If you'd like to ask a question, please press #6 to unmute your line to ask a question over the phone, or you can pose a question in the chat box feature. We'll take as many questions as we can. However, please be assured if your question is not addressed during this webinar, we'll make sure someone gets back to you and address your question via email. Thank you.
So #6, anyone, if you have a question or a comment, or let us know how things are going.
All right, I know Carol and I are really good, but somebody has to have a question out there.
I know. I'm sitting on my hands right now. How about you, Michael P.? Do you have a question from your facility? Julie wants to know.
Yeah.
So #6 to unmute your line.
Michael, don't disappoint me now.
I'm sorry. I thought I was unmuted. I answered. I do not have a question at this time.
How about a success story, my friend?
We are using the Stop and Watch, and we have housekeepers are doing the Stop and Watch. A lot of PT, OT, speech therapists use the Stop and Watch very frequently.
Thank you very much, sir.
And how often, go ahead. I'm sorry, Florence, go ahead.
Julie, Ed Martinez would like to know where he should send his completed checklist form.
I'm surprised that we have checklist forms. I haven't sent it out for this year, but you're welcome to email them to me directly, please, and thank you.
So, Julie, why don't you put your email in the chat box? That'd be great. Thanks, Ed. So, Mike, I'm going to come back to you. When you're using that Stop and Watch, and let's say a housekeeper fills it out saying that they feel there's a change in one of the residents, can you walk us through the process of where that form goes and who communicates what and how does it end?
So let's say a housekeeper will give it to, usually it's, we'll give it to the nurse, and then the nurse and the supervisor will discuss what's going on. They'll assess the patient. If they need to call in our PA, the PA will come in and assess them from there, and then it's a morning meeting the next day.
So at the morning meeting, the outcome of what the PA or the nurse finds is discussed.
Yes.
And then, does anybody get back to the housekeeper?
That is sometimes, not all the time. That is one thing we need to work on.
Okay. Okay, good. So you know that that's part of the process, but that's a gap that you can work on. Excellent. Thank you. Good.
Thank you for that. That's a very important part of using the Stop and Watch. It's important, even if it takes a week, it's important to get back to that non-clinical person who completed that tool, because you want them to feel that they've completed the tool and somebody actually did something, information that they provided. Nothing worse than doing something and not having kind of feedback.
Yes, I agree.
Exactly. Good. Now, do you use the Stop and Watch for families? Have you implemented that yet?
No, I haven't thought about that, but I think that's our next step.
Family and staff, have you ever heard anything about that? No. Stop and Watch the residents. I'm going to see if I can print something out.
Okay. There were 9 answers.
Thank you. So in the chat box, Bev from Vernon has said we found that along with the red envelope, we include a white envelope for EMS personnel, exactly duplicate to ensure the red envelope gets to the emergency department.
Actually, Bev, can you unmute yourself, pound 6, if you're muted? Can you tell us about your success story? Sorry, Carol, I wanted to catch her before she got off.
Absolutely, no.
Deb, we're waiting for you.
Pound 6.
All right, well, keep talking, Carol, until she can unmute herself. Sorry.
Yeah, no, I think that's a wonderful idea. Again, the white envelope, that's a really nice place, nice handoff to EMS, but EMS has said to us they don't need the envelope. They just want the documents because they need to know their meds, they need to know their advance directive, they need to know contact information, they need to have that face sheet for billing information. So it's again, so they can carry on with the acute care that needs to be done in the ambulance. But that's great that Bev from Vernon has put this process in place, and we would love to know how's it going.
And Bev also had a story, and this is what I was wanting her to report off on. She talked about having success with the Stop and Watch with housekeeping. Being the first to alert them to any possible resident issues. We talked about how housekeeping and sometimes dietary, because they spend a lot of time in the rooms with the residents, and they will see things before any clinician sees it. So thanks for validating that for us, Deb.
Excellent. So Stop and Watch is an outstanding tool. Can anybody sort of tell us any success stories or barriers with the the SBAR form? We know it's long, it's 4 pages, but you don't have to fill out it all if it doesn't relate to the acute change in condition of your patient, of your resident, excuse me. You only fill out those areas that are related to what you are assessing.
And the 4.0 version of the SBAR is now just a front and a back.
Oh, excellent. I did not know that. I'm sorry.
If you have points to care, it's already built into your EHR, and all you have to do is just work on it on the computer, and then just print it out to send with your resident.
Anybody have a success story or a challenge? Bev is trying to unmute, not being able to. No, pound 6, Bev, not star 6. Pound 6. Is that you, Bev?
Maybe it's hashtag 6Bev. I know you'll probably, up the latest terms. Hashtag.
Poor Bev, she's trying. We can feel her angst. We can.
Are you sure she's there?
Well, she's typing. She's typing. So if nobody wants to talk about SBAR, how about your data, your readmission data? Does anybody have any success stories about what you have done with the data that you're able to pull off from the website, the nursing home quality improvement website?
I think I'm finding.
Because without data, you don't know which way you're going. So you really need to, as Florence said in her presentation, that you need to start your meetings, no matter what meeting it is, whether it's an interact meeting or it's a falls or pressure ulcers, you have to have your data.
I think
you don't know which way you're going. Yep. All right. So nobody's in the mood to talk. It's good to share. It really is good to share. All right, Florence, do you think we've had a good call?
Yes, I do. I move on.
Okay, well, I just want to say thank you to everyone who was on the call today. Florence, you did an outstanding job to talk about what Interact Nursing Home should look like. And again, it takes a good amount of time, over a year, to get those tools implemented. And you got to monitor the tools to make sure that they're still being used, that they're being used appropriately, that if there are barriers out there, that the team can address the barriers. So your frontline staff doesn't have to jump through hoops to get things done. And if you do have any questions, concerns, or you just want to touch base with us to say, hey, can you come down and see how we're doing, you have our contact information on the last slide. Those are our email addresses as well as our phone numbers. We are just a phone or a click away, and we would love to help you. As Florence says, we would like to be the one state in the United States that has the entire state covered with red envelopes, because that means that they are Interact homes. It's not just the envelopes, but what it really alludes to is that we are an Interact quality improvement program state. It's all about improving communications and improving care for our residents. So with that, Julie, you have a couple of housekeeping.
Everyone, thank you for a great discussion. A last few announcements before we end today's call. So a reminder that we're now on social media. You can visit us on Facebook, LinkedIn, and YouTube. When you close out of this webinar, the evaluation is going to automatically pop up on your computer. It's only 3 questions. Please do that if you can immediately. We'd like to get some feedback, know how we're doing. If you don't have time to fill it out, again, it's only 3 questions. If you don't have time, and you're currently sharing your computer with somebody, you'll receive an email tomorrow with the link to the evaluation as well as the link to the event page. So if you don't tell us how we're doing, we're not going to know. So please, if you could take 30 seconds, we appreciate it. The PowerPoint presentation is in your Day of Details email. That's going to be posted on the website. We're going to have the updated dates for you. Again, the date to submit everything to us is going to be January 16th of 2018. I believe that's a Wednesday. By close of business, please. Thanks again for attending. You can email me anytime if you have any questions. We really appreciate your time with us. Have a great day.
Thank you, everybody.
Bye.